quite a lot of background noise. If everyone could go on mute, that'd be really helpful. Thank you. Brilliant. So welcome today, welcome in August. So there's we normally get really huge numbers, between 100 and 150. So I'm not sure we'll get quite up to those numbers because we're in August, and that's really good to know that our colleagues are having a break, and hope that everybody on here has either had a break or getting a break over the summer months, because we are all exhausted. So know that we really need to. Really pleased I can see Sue already here, Sue Laurent, who's a beloved retired paediatrician, and she's going to be speaking to us today. So really great to see you, Sue. We are continuing to have these events on the first Wednesday of each month. We think September, for technical reasons, might not be the first Wednesday, but in future we will look to do them on the first Wednesday of each month. And we know feedback pre-books, if you could all go on mute, that would be really helpful. We know feedback from the last session was that the vast majority of you wanted to keep these virtual because they were easy to attend, eat your lunch, and you can leave your cameras on and have your lunch eating in the background. We do not mind, but we know that then you haven't got travel time, and in an increasingly busy world, virtual is the mode for how you want to do these Pan Barnet meetings. If you have any requests for specific topics or speakers, either let us know, either Anisha, myself, or any of us, and or you can. Emily is submitting a form, so you can fill out that form that's just gone in the chat in terms of a link to a hub feedback form. So as I said, really happy to see Sue Laurent here. So she's a Director of Medical Education, retired paediatrician from Barnet, and also the Medical Director from Noah's Ark Hospice. And those of you who went to one of the last meetings will be aware that she presented on that phenomenal hospice that's within our catchment area. We haven't addressed paediatrics for a little while, so Sue's going to be starting us off with a quiz on rashes and slides on limping child. And then what we're doing is opening up to questions from you, because we know you'll probably have lots of questions. So please start thinking about them and have your questions ready for Sue. You can either post them in the chat, or you can raise your hand or unmute if you've got a comment. In terms of CCG updates, just want to say a huge thank you to everyone. 51 out of 52 practices signed up for the enhanced specification to deliver phase 3 of the COVID vaccine. And I almost cried when I saw the figures across NCL, because I know how hard it is, I know how tired people are, but actually this commitment to do something which we know is probably one of the most effective medical interventions we will ever do in our medical careers, actually the commitment to carry on doing that for the boosters in phase 3 is hugely appreciated. So really many thanks to all of you, because I know it's not easy to decide whether you sign up, and we have mostly across the same footprints, a little bit of change in some of them, but we're doing the assurance visits over the next week, and so far so good. So the programme will be running from September. It was envisaged December, it might carry on a little longer beyond that, and across NCL we're looking to do the Pan Pan borough support for the vaccine programme. In terms of system recovery, just to give you an update, in terms of dates and times, the X-rays at the Royal Free are between 3 and 5 days. Ultrasounds are 5 weeks for in health and 7 to 8 weeks at the Royal Free. ECGs and 24-hour blood pressures are 1 to 2 weeks at both in health and Royal Free. And in terms of the weights for different specialties, I've got a figure, I've got a slide, but it's actually from June. It's updated every 3 months. But I think what I'll do is post it in the bulletin for you, so you can see that on Friday. We also, I think, have here, I hope she's joined today, Kat Wilson, so Kat Watson. So I don't know if you're able to come off camera, Kat, just to say hello and to introduce her. So she is the new, hi Kat, nice to see you. She is the new lead for primary care in Barnet. So just you can put a face to the name, and she is hugely involved with the COVID programming and is getting to know everybody, and particularly the PCN CDs. Welcome to Kat. So really thank you to everybody, and I really do hope everyone gets a chance for a break, because it's been really busy, and I'm sure it's going to be a very busy winter. So I think I probably won't say any more, and I think I'm next handing over to Anuj to the Federation from an update. Many thanks.
I'm standing in for a new Charlotte. It's Michael, and I'll go through the slides fairly quickly. So if you go to the next slide, please. Support to housebound patients continues with over 400 to date, and new referrals still coming in, and we're looking at phase 3 with the CCG. We have a hybrid support offer in operation for the PCNs in terms of phlebotomy. We're supporting 6 of the 7 in different forms. If we move to the next slide, please. We should have month-end reporting for our flexible EHS offer. You can see all the different staffing groups that we've got. That should be ready by the end of the week. And I think we normally advertise our anticoagulation service, and the stressing it is available from 4 sites across the borough, and the days are there, so it's across the week and 4 sites. We go to the next slide, please. We provided the additional capacity in June and July for practices and 111, almost 2,000 additional appointments. There's currently no plans for this to be extended into August for practices, but that is traditionally a low usage month for us. We have had some problems with the EMIS migration, have all been resolved now. If anyone, any clinicians working in our service have issues, please do call the on-call manager. And if any practices are struggling, please contact our operations team. But we seem to have got through all those teething problems. And we're also going to be going out to recruit again for more salaried and sessional GPs. So if you're interested, contact us, or if you see any of the adverts, please respond. And the last slide is just giving an idea of our cumulative activity with EAS, and we're running to plan with those above plan levels in June, July, and also activity in August for 111 to address those pressures. Right, thank you. Don't know if there's any questions.
Brilliant, thank you, Michael. I'll keep an eye on the chat just in case there are any questions for you. Hi everyone, it's Anisha here. I've logged on under my colleague's name because I was having IT issues. Just a quick training hub update then for everybody. First of all, we just wanted to flag that there's to the GPs in the group, there's an opportunity to support the VTS, so the GP training programme in Barnet. So on Thursday afternoons during our VTS time, when the trainees all come together, we have weekly trainee small group sessions, which is a balanced style small group case-based discussion where trainees come and discuss any issues they're experiencing and discuss any tricky cases too. And there is an opportunity to facilitate one of these groups. So you'll be required for 1.5 hours, 3:30 to 5 on a Thursday afternoon. And it's a lovely thing to do. I facilitate a group as a PD, and it's one of my favourite parts of the week. And it's a great opportunity to get to know the GP trainees as well. So if you are interested in doing that and facilitating a group, unfortunately it is only open to the GPs, please just contact me. And I'll also post a link for it in the chat in just a moment. The other thing that I just wanted to flag was an opportunity for practices who are looking to recruit nursing staff. So as we know, the number of practice nurses being employed nationally and especially in London is falling. So HE have decided to fund a GPN, a general practice nurse training programme, and provides the funding for the training and also some cost towards the nursing salary once they complete their training. So, and the training hub can also offer educators to come in-house into your practice to support the practice nurse to address their training needs. So that programme starts in January 2022. So if you are interested, so for example, you're looking to recruit a nurse or some of your nursing staff are looking to retire soon, this might be for you. And if you want more information, please just contact, it'll be Amita Shah from the Training Hub, and I'll also post her email address in the chat for you. So that's nurse recruitment. And the last thing that we just wanted to flag from me was a Singing for Better Breathing programme, which is available, a free service available for people with chronic lung disease such as COPD, asthma, fibrosis, or even long COVID. And it's a weekly singing and mindfulness group. And it sounds fantastic opportunity for our patients. So we'll also post, I don't know if Emily's already done that, but if you have, if you wouldn't mind then just reposting that poster, and just a reminder really to refer your patients into that because it does sound really great. Thanks everyone, that's it from me. I'm just going to hand over now to Famida, who is our pharmacist lead from the Training Hub, just to talk us through some opportunities from her side. Thank you, Famida.
Thanks, Anisha. So I just wanted to update you on the pharmacy technician apprenticeship training. So Health Education England has managed to secure funding to expand the pharmacy technician apprenticeship training program. So this is money that can be used to train up people to become qualified pharmacy technicians. Thanks. Yeah. So last year was the initial rollout of the scheme. And as some of you may know, the training hub supported and submitted a Barnet-wide bid, which was successful. So we now have 6 trainees in post working across Barnet. Just a few points to note is that it is a 24-month apprenticeship program, full-time. However, the trainees are required to attend college 1 day a week. So they come in for 4 days and attend college 1 day. Has to be cross-sector training. So it could be a GP practice with a community pharmacy, for example. So this is just to give you an overview of the partnerships that we have currently in Barnet. As you can see, we've got 3 partnerships and 2 trainees in each partnership. So if we look at the first one, we've got Dr Azim and partners with Warman Freed Pharmacy, and they're jointly supporting 2 trainees on a 2-weekly rotation across the sectors. So there is flexibility in how you set up the rotations. You can apply as an individual practice, or you can go via the PCN route as well. The partnerships that we have at present, the GP is the main, is the employing partner in the partnerships we have at present. So how much is it going to cost you? So the figures that I've used here are from the current cohort. We haven't got the new figures yet from here, but we will be getting that shortly. So if you think about this as generally in each partnership, there'll be 2 partners and 2 trainees. Any cost that's not covered by the funding is shared equally between partners. So the best way to think about it really is any shortfall is, for each trainee, each partner picks up the shortfall for 1 trainee. So if we look at the very bottom row, for 1 trainee, it's going to cost just over 45.5k over the 2 years. And this includes salary and on costs, which we've calculated at 30%. If you take away the funding provided by here, you're left with a 13.5k shortfall. So this is what it will cost you in total. If we break it down further, it's sort of 6,750 per annum. And if I've got my sums correct, probably about £32 a day. So a real bargain. Now, deadlines will be very tight. As soon as I get the figures from here, we'll can let people who are interested know. But my understanding is that we will be getting more funding this year to reflect the time it takes to train and supervise these trainees. This year, we were able to claim a government grant of 2k. So I think the sums will probably look a little bit more favourable. So if you're interested, please, feel free to drop me an email. I'm happy to talk you through it and answer any questions. Please, if you can, do it in the next couple of weeks. If there is enough interest, the training hub is happy to support a Barnet-wide bid again. You can, of course, apply on your own, but generally the system-wide bids tend to be a little bit more successful. So we'll send out the slides and an expression of interest form after the meeting. But yeah, that's it, I think.
Thank you, Famida. That's brilliant. It's really good to hear about these opportunities in Barnet. Just make sure practices are really making the most of it. And yes, Famida, we can circulate your slides afterwards. So thanks so much for that update. Before we hand over to Sue, then, I'd just like to hand over to Suzanne Lever, who is our medicines management lead, who's going to update us, amongst other things, on the latest NCL type 2 diabetes guidelines. Suzanne, thanks so much for joining us, and over to you.
Thank you very much. Before I start on the diabetes, I just wanted to give a little update on our new process for managing queries. So the medicines management team. It would be really helpful if all practices, PCN pharmacists, etc., could use the medicines management team generic mailbox to direct queries. That way, we can make sure that that queries are dealt with in a timely manner. And if somebody is off, we can make sure that the query doesn't sort of get stuck in their inbox and it can be dealt with quickly. The other thing is we can look at the number of queries coming through. And if we're getting continual requests for the same thing, we can maybe add this to prescribing watch and deal with this for everybody. The next slide, please. So I just wanted to take the opportunity to signpost to the new anti-hyperglycemic agent guidelines, which are now on the North Central London Medicines Optimisation Network. You may have noticed that this actual site has been down for the last 10 days or so, but I've been told that it's now the the problem has now been fixed, and hopefully it will be up and running in the next couple of days. So please bear with us on that one. So there has been this new NCL interim guidance is in place until the NICE NG28 guidance is updated, which won't be for another possibly up to a couple of years. And there are some significant changes. The choice of treatment is based on cardiovascular and renal comorbidity. And the guidance gives a really lovely table on the place in treatment of all the different anti-hyperglycemic agents. The SGLT2s are a second line option unless contraindicated or severe cautions. And the guidance does also give us sort of a table about this, when they can be used, and also cautions to look out for. And the choice is dependent on evidence base, which is also included. With regards to GLP-1s, the guide gives a table on the NCL formulary choices, and they are now third line for patients who have cardiovascular or renal comorbidities. In there, the oral semaglutide is actually included as a last line choice, where a GLP-1 is indicated for and weight loss is a secondary benefit. The reason for this is that there's no cardiovascular outcome data, and also the efficacy is not as good as subcut semaglutide. And the other issue with oral semaglutide is that it needs to be taken on an empty stomach, i.e. a patient has to fast for 6 hours before it can be taken, and then they have to wait at least 30 minutes before they can have any other medication, food, drink, cup of tea, anything. So it does need counselling. Just wanted to make sure to say it is in there, but it would be a limited number of patients who would be eligible for this. And the next slides, please. Thank you. And the other thing that has updated recently, which is also on the Joint Formulary Medicines Optimization Network website, is the glucose and ketone monitoring guidance, which is some lovely guidance providing some really clear choices or new meter choices for type 1, type 2 and patients with diabetes in pregnancy. It also gives information on frequency of testing and some information on prescribing of strips for patients who are also using Freestyle Libre or insulin pumps and continuous glucose monitoring. The guidance gives information on ketone monitoring, and there's a revised section on the DVLA. So it is definitely worth dipping into that, and our script switch messages will link to both of these guidance when they're up and running. So hopefully the access will be easy. So that's that from me. Thank you very much. Any contact at all, please use our generic email address, and it'd be lovely to hear from you. Thank you.
Brilliant. Thank you, Suzanne. That was really helpful. And actually, I've had a look at the NCL diabetes guidelines, and they are brilliant. They're really well laid out, really easy to follow, and very helpful. So I'd urge everybody to have a look. In fact, I will circulate them because Suzanne sent them to me again. So I will circulate them after the meeting. So thanks, Suzanne. Good to hear about oral semaglutide as well. Okay, lovely. So we'll now move on to the bulk of our meeting on paediatrics, and I'm very happy to hand over to Sue. Sue, thank you so much for joining us.
Thank you very much, Anisha. And I noticed that I'm also joined by one of my eminent colleague paediatricians, Paul DeKeyser. I've seen you're there. Hi, Paul. So if you want to join in at all, or I get anything wrong, please do. He's also a GP, so he's very, very clever. Anisha gave me two topics. One was rashes, just general rashes, and the other one was the child with a limp. So I thought, why don't we just start off with a rash quiz? Just to see how up to date you are. There's nothing mad or nothing trying to catch you out at all, but I just thought it would refresh your paediatric rashes. So let's go to the first slide. What I'd like you to do is to put into the chat what you think this child might have. Now, obviously, just looking at a child, you need a lot more information, don't you? So I want you to be thinking about the differential diagnosis. And I'm going to add in that this is a miserable child. That's all I'm going to tell you. So what do you think this could be? And I'll give you just 30 seconds to to write down what you think it could be.
Okay, so we've had Andrew, Hillary, we've had quite a few. I'm not going to read out everyone's names. Loads of people are saying measles. Anna, Geeta, Stephen, Manu, loads of people are saying Rosalind.
Absolutely wonderful. Yes, so this is measles. What's really interesting is that some of our junior trainees now, when we do get the occasional case of measles in Barnet, have no idea what this is, because we don't get it very often. You get it little mini epidemics. But obviously it could be a whole number of other things, couldn't it? There are lots of sort of viral exanthem that look rather like that. And just looking at this child, you'd need a lot more information. Okay, slide 2. So what do we think she might have? She's not so miserable as the first child, but she has got a sore throat. So any idea?
Emma says parvovirus.
Could be slap cheek, could well be.
Andrew says slap cheek. Jonathan says slap cheek. Barry says scarlet fever. A few more slap cheeks.
Yep. So you're absolutely right. It could well be slap cheek. This is actually scarlet fever, and one of the features here is the circumoral pallor. So you've got this white area around the mouth. But if I showed you her tongue, we'd obviously see a scarlet tongue. Okay, next slide, please. Okay, so this is the one where I've always loved the child that comes to A&E and they've been backwards and forwards to their doctor multiple times and nobody knows what it is, and the rash has been going on for a few weeks and it's sort of sandy feeling, a bit raised, a bit scaly, slightly itchy. Any thoughts?
Minnie says ringworm.
So great list, and it's actually pityriasis.
We had a few.
Pityriasis rosea, and you've got the herald patch there, which is one of the things. But particularly, if you look at the back of this child, you will see a Christmas tree distribution of rash. And it's one of those things where you cause a lot of reassurance to families because they've been going backwards and forwards, getting more and more worried, having more and more treatments applied. And eventually somebody says, that's pityriasis. It goes on for a few months sometimes, but it will get better. Okay, next slide. Okay, any thoughts about this? And I particularly shared, unfortunately, I couldn't find a child, but this is a sort of elongated adult. It's not the length of the fingers I'm looking at. It's the fact that this rash it's all over the body, but it's particularly on the palms and soles. Yes, absolutely. Erythema multiforme, straight on in there, Hillary. Well done. And it is, the thing about it is it affects the palms and soles. It has often a sort of central area which can be, it looks a bit like a target. So you've got a central dark and then a light and then a dark area. Sometimes it's kind of a mauvey type of hue. And again, it can go on for several weeks. Lots of different causes, can be viral, can be bacterial, can be secondary to antibiotics. So if you think there's a definite virus that's caused it, you can treat it. Well, you can't treat it. If you think there's a definite bacteria that's caused it, you can treat it. With obviously a virus, you don't. And if they're on an antibiotic, you might want to stop that because that might be causing it. Okay, next slide. This is another really miserable child. Anyone got any clues? Quite young, probably around the age of 2 or 3.
Armour, Mitsu, Penny, say Kawasaki.
Absolutely, you've all gone straight for Kawasaki. Absolutely right. But again, you know, when Kawasaki first presents, it can look quite like measles, actually. You can have a rash all over, you can have very sore eyes, and it's as it evolves. The thing about Kawasaki's is always to think about it, because of all the rashes that I've just mentioned, this is one that really needs diagnosis and treatment. And unfortunately, there is no blood test to diagnose this, so it's a constellation of symptoms together. And then eventually, when you think that it might be Kawasaki, you're going to want to give IV immunoglobulin. Now, Kawasaki is a constellation of symptoms. So you get a fever for more than 5 days, together with these sore eyes, often a very sore tongue and swollen, cracked lips, huge big nodes in the neck, a rash, and peeling fingers and toes, initially swollen fingers and toes, and then peeling fingers and toes. And the difficulty with making the diagnosis of Kawasaki's is that you need to make it less than 10 days after the first symptom. And so sometimes people are still worrying about a child, not knowing what it is. They've sent off every blood test, they don't know what it is, and now they've reached 10 days. And the reason you need to make it less than 10 days is because you need to give IV immunoglobulin for treatment. And it is like a miracle. It's one of those things in hospital where you have a child who's utterly miserable, who looks like this, whose fever has been raging for several days. You give IV immunoglobulin and you also give aspirin, and the temperature just plummets and goes back to normal, and the child is better. Does anybody know why it's important to treat with IV immunoglobulin? What are we trying to prevent? I'm looking at that chat line. Absolutely. Well done, Anne. Yes, so it's really, we're trying to prevent coronary artery aneurysms and therefore long-term cardiac disease. So really important to pick that one up. But of course, giving IV immunoglobulin is giving blood products to a child. So you've always got to sort of weigh it all up. I would say in hospital, we tend to diagnose it earlier and earlier. So we usually diagnose it as under 5 days because of the constellation of symptoms. But we always have to share the risk with parents. We always have to say, we think this is the most likely thing that we've got here, but that it may not be. But we think that on balance, we should be giving immunoglobulin here. And we always give these children high dose aspirin to begin with. And then we follow them up with we do initial echo, follow up with echo, and then we can decide how long to carry on the aspirin with. And this is one of the very few conditions where we give aspirin to children, because as you know, aspirin is completely banned in children otherwise. Okay, next slide. Okay, so this is a child who has had some tummy ache and doesn't look particularly unwell. Any thoughts? And you might test their urine and you might find a bit of blood in the urine. HSP, absolutely. Well done, Anne again, and several others, and Charlotte, well done. HSP is one of those great diagnoses to make because you just make it by looking. There's nothing else you need to do. Obviously, we need to exclude a few other things. So you want to make sure you haven't got a child who's got low platelets. You want to make sure that you haven't got a child with meningococcal disease. So you will be doing other tests. But actually, it's the constellation of symptoms, because it's a vasculitis, that makes HSP an easy diagnosis. And for most of these children, their long-term outlook is very good. A few will go on to have a chronic nephritis. So we always follow up these children. Initially, we follow them up we send them home, and we have a home care nurse that follows them up. And then we always review them again at about a year to look at their renal function and to see how they're getting on. The other thing that we follow them up for is their blood pressure, because some of them can become hypertensive because of the vasculitis. Okay, next slide, please. Now, this child is really miserable and is lying there, opistotonic on the bed, looking sick, sick, sick. What do we think about this child? Any thoughts? So this is, gosh, Anne's really on it. Well done, Anne. I'm going to tell your sister, who I'm still very good friends with. Yes, so this is meningococcal disease. And, you know, I have to say that I can't remember the last time I saw a child with meningococcal disease. It's been a really long time because of the way that we're vaccinating. The peak ages are in young children, in babies, and then in students. Those are the two ages that we have to really make sure we're well vaccinated. But when you do see a child like this, it's obviously all about treating it within the first hour, and it's inotropic support very often. It's a lot of fluids, getting their antibiotics in very quickly. But you all know that, so I don't need to tell you. Right, next slide, please. So that's something you're seeing general practice all the time, and you're reassuring. Who knows what that is? It's molluscum. Yeah, and I can't tell you how many parents they come to us and they say, while I'm here, can you have a look at this? Can you give me some treatment for this? And I always really empathize, and I always say it's going to be there for months and months. It will eventually all go away. It's a virus, but I don't offer any magic treatments. Does anybody on this chat offer any magic treatments for molluscum? If you do, I'd love to know what it is. I always say all of my children had molluscum as well for long periods of time. And sometimes they pick them and then they look horrible. Oh, look, there's Jonathan. Hi, Jonathan. Yeah, Anne's beating you, Jonathan. Right, next slide, please. Okay, and that's another thing that you'll see a lot of that we don't see very much of in hospital, but we do occasionally. These children rock up to A&E. Anyone got any idea what this is? It could be impetigo. It's actually not impetigo. It could be HSV, and it's not. The clue is, I'm going to say that he's also got it on his hands and his feet. Yes, it's hand, foot, and mouth. Oh, look, all these familiar names here. It's fantastic. Hi to everybody. Okay, let's go on to the next one. So I put this up because I remember this from when I was a student, and I thought, oh, you know, I've always got this in my head to remember that when the rash appears on the day of the illness. So the child gets a fever, and if it's on the first day, rubella is the most likely thing. And do you all remember really sick? Can either be children or really sick patients, because you can have the P for pox or the C for children. So really sick children must take no exercise. That's what I learned when I was at medical school. Anyone else remember learning that? And so rubella on the first day, scarlet fever or smallpox. Luckily, we don't see smallpox anymore on second day. Chickenpox is on the third day, although it can sometimes happen a little bit earlier. Measles is the fourth day. And I always remember that, but the Koplik spots appear on the second day in measles, and sometimes the Koplik spots are not there by the time that the main rash appears. Typhus, don't see typhus. Anyone ever seen typhus? I haven't. Then there's supposed to be nothing on the sixth day, although I found out that actually dengue fever recently can be on the sixth day, and we see more of that because of extensive travelling, and then enteric fever or typhoid on the seventh day. That's one of those illnesses when it's actually very late on that the fever develops. So that was just a mnemonic just to take me back to my student days. And I bet some of you, Jonathan, for example, or Andrew Frankel, I bet you remember all of that. So let's move on to the next part of the talk, which is the limping child. So we see lots of limping children in A&E, and I'm sure you see lots of limping children in general practice. And I thought the way of thinking about it really is this an acute or chronic problem? And of course, the ones that we tend to see in A&E are going to be the acute limps. And then you can divide them up into the age, because certain things happen more commonly at certain ages. Obviously, the first thing we're going to ask about is a history of trauma. But I suppose if you've got a history of trauma, that makes things generally much easier. Although do beware a child who's had a history of trauma and comes in limping, and actually they've got something else, and they get ignored because everyone assumes it's because they fell over, but actually that just revealed that they had an osteosarcoma. So then go to have they got a fever or not, and that's really important. So a fever and a limp in a child is a reason for us to see the child acutely, because they could have, as you all know, an irritable hip, very, very common, or they could have either a septic arthritis or an osteomyelitis or something more serious that needs urgent treatment. Have they got a rash? Have they got any obvious signs of an arthritis, so swelling or redness of joints? And is there any sort of prodromal illness? Next slide, please. So on examination, I mean, obviously one of the things you're going to do when you take the child in from the waiting room is look at their gait. So what kind of a limp have they got? Is it because actually they've got a leg length disparity, or is it a limp because they're in pain and they're not weight bearing? You're going to assess their range of movement. I mean, I always found, I don't know about you, but a musculoskeletal examination was something that really eluded me as a medical student. And I still love it when somebody else does it, because I sort of wiggle their limbs around a little bit like this and say, yeah, full range of movement. But when you see a physio do it, it's just so much better. Have they got any rash or bruising? So, you know, HSP, things like that. They often get very painful ankles or knees. Have they got any local tenderness? As I said, leg length disparity. So next. So I suppose number one in the children that we see in paediatrics in A&E is going to be an irritable hip, and I guess that's what you're seeing. And it can be in any age child, but it tends to be in the toddler or the younger child. And as a child who's usually had a fever, a viral infection, suddenly starts to limp, suddenly starts to complain of pain. It's usually in a hip, but it can be another joint, but usually in the hip. And generally, what we would do is we would do a set of bloods to reassure us that there wasn't any obvious underlying infective cause. So you haven't got a high CRP or a very raised platelet count. And if you've got sort of normal bloods, we would send the kids home and give them some analgesia and follow up and just say, let us know how they're doing, and hopefully it will just get better. But what we're obviously trying to exclude is osteomyelitis and septic arthritis. And those two can get missed for quite a long time, because the majority of children are going to be irritable hip. The majority of what we're doing is reassuring. So osteomyelitis can be really hidden. And we've had numerous cases I can remember over the years of children who haven't been picked up for, like, they've got some little area sort of in the pelvis or in a long bone of osteomyelitis that we just haven't found. Septic arthritis, you're going to be much more likely to see a swollen joint. And obviously, if you think you've got one or the other, the ideal treatment is going to be to investigate and find your organism first before starting antibiotics if you can. But then we can often have a bit of a tussle with the orthopedic team, because we say, we'd like you to take this kid along to theatre now and aspirate their joint. And they may say, we can't do it until tomorrow. So then we'll say, well, we need to start antibiotics now. So you've got a bit of sort of give and take there. But the other things to just not forget about are the slit upper femoral epiphysis and Perthes disease. So SUFIs tend to be in the older, slightly overweight child, where you actually get the sort of the head of the femur slipping over, so that you can, and you see it on X-ray. But really important to do that X-ray and in the right position to exclude a SUFI. And Perthes tends to be in the younger child, where you get an avascular necrosis. And one of the biggest pitfalls that people get into when they're investigating this child is that they X-ray the wrong bit. So the child presents with a pain in the knee, and they get knee X-rays, and they carry on with their pain, and they carry on with their limping, and then eventually somebody thinks, but this might be a hip problem, and so they do the right X-rays, and then you get your diagnosis. So those are two things not to miss. They're both relatively rare, but really important things, and obviously they go straight to our orthopedic colleagues. You can also have congenital dislocation of the hip, which has been missed at birth. And actually doesn't particularly cause any pain, doesn't particularly cause any problems with crawling or rolling. But when the child starts to walk, and they usually walk on time, they will limp because their hip is right out of its socket. And that's when it gets diagnosed. And that's not when you want to diagnose it, obviously. But again, another really important one to image. The things that can catch us out with limp are things like cerebral palsy and also space-occupying lesions in the brain. So you can get a child presenting as a new limp, and actually there's something going on. Either their cerebral palsy is mild and it's sort of evolving, or they've got a space-occupying lesion. And I've certainly seen a couple of children with brain tumours who presented with a limp. And then things like juvenile arthritis, again, they're pretty rare, but they do happen. But you have to look for signs, evidence of an actual arthritis, so an active process of inflammation going on in a joint, one or more joints, and investigate and refer appropriately. And then last but not least, again, very rare in that it rarely presents with a limp, but I have seen both leukemia and sarcoma presenting with limp. And particularly leukemia, you might get bone pain, and I've even had a child who presented with bone pain and absolutely normal bloods and normal differential, but there was something about this child's bone pain that really worried me, and so we did a bone marrow aspiration, and we diagnosed really early leukemia before it had spilled out into the peripheral blood. So always, these are the bottom of the list things. And for you as GPs, I mean, irritable hip has to be, if it's not trauma, has to be really high up on the list. Okay. So first of all, we're now on to our Q&A section. You can, any questions about anything I've said already, and obviously I've just kind of rushed through two huge topics. I didn't mention eczema at all in my talk, because eczema is really an hour-long talk. And in fact, as far as I'm concerned, it's just lots of emollients and lots of steroids, and make the child look white when you've sent them out of your consulting room, which is what our dermatologists do, white with emollients. But I'd love now to take any questions that you have, and fire ahead.
Brilliant, thanks, Sue. There's one from Andrew, who Suzanne Lever's sort of semi-answered it and talked about the patient purchasing at the counter, but he said, can we suggest Moludab for molluscum?
I don't know, so you tell me, because I've never treated it with anything, so I'd love to learn if you've got something that you think works. I love that term, Moludab. Yeah, it sounds like it should work, doesn't it? Has anyone got any experience of it working?
It's potassium hydroxide. I don't know. I think anecdotal, there's no evidence. So basically, if patients want to try this, they can purchase it. But to be honest, it's, as you say, it's self-limiting.
Yes.
You know, it's probably like everything, 6 days, you know, 6 weeks with, 6 weeks without. You never can tell. But yeah.
Exactly. Thank you. Yeah. I wish somebody had come up today. Out of 92 of you, at least one of you should have known how to treat molluscum. But sadly, you'd make a lot of money if you found a treatment.
Well, Andrew says, speaking from experience as a parent, it didn't really work.
No. Thank you, Andrew. Okay, any other paediatric questions? Oh, and Paul, have I said anything wrong? Do you want to contribute at this point?
So any questions for Sue, please post in the
Paul.
chat.
Hi, you're outside. Hey.
Yeah, my only comment, because I've got a one-track mind, is that if there are marks where there are potential safeguarding concerns, then you know who to ring. And we've got a brilliant.
Good point.
We've got a brilliant new designated nurse called Caroline Loke, who's taken over from Siobhan. So thanks, Sue.
Thank you, Paul. Thank you. I'm glad you're outside.
My vitamin D.
Oh, excellent, excellent. Yeah, I completely agree with you. Yes, obviously, anything safeguarding, any rash that could be safeguarding, let us know.
Any other questions for Sue? Please post them in the chat, or feel free to unmute or raise your hand, whatever you prefer. Yeah.
Any burning paediatric issues that you're worried about right now? While I'm waiting, just to let you know that we've now uploaded onto your central system the Noah's Ark referral form, so that if anybody wants to refer somebody or thinks that a patient that they have might really benefit from the sort of holistic care that we offer children with life-limiting conditions, then please let us know, and you can just send it. And I understand you've got this system where it kind of, your forms can get pre-uploaded with all their information, which sounds, I wish we had that in our hospital.
Yeah, so hopefully it's on Bar Global.
That's the one. That's the one. It's on there now.
Excellent.
Yes. Yeah. Gosh, no questions. This is amazing.
I know. But Katrina says, thank you. I found that really interesting and enjoyed the presentation, Sue. Non-GP here, but a mother of a 5-year-old.
Oh. I tell you what, you could do most of what I do, Kat, because a lot of what I do is parenting stuff.
Jonathan, I've been asked to refer a child by a GO's, what's a GO? Do you mean a GP? Rheumatologist to paediatric podiatry and paediatric OT. I cannot see any forms on Bar Global. How do I refer? So Sue, can we refer directly to paediatric podiatry and paediatric OT, or does it have to go via, oh great, Ormond Street, thank you. But does it have to go via paediatrics? Have we lost Sue? Maybe we've lost Sue. Well, let's wait a few minutes for her to join back. Sarah Shelley says child development referral.
Yeah, and also general paediatric clinic, because very often the physios or podiatrists want us to exclude a neurological problem.
Okay, so you think some of these children might need a general peds referral, but Sarah says there's a child development referral form on Bar Global. Thanks, Sarah.
Just said you've been removed from the meeting. I just went.
You're back now.
I'm back.
Good. Thanks, Lena. We just addressed a question from Jonathan about pediatric podiatry or pediatric OT, but I think we've had that answered by either a general peds referral or a.
All here for. That's great.
Yeah, or a child development referral.
Yeah.
Jonathan said thanks. It'll be easier to refer to general peds.
We do everything.
Any other-
It's crazy in A&E at the moment. Apparently in paediatrics at the weekend, there was something like a 9-hour wait. I mean, it's just gone. I mean, everywhere, all frontline services right now have gone completely bonkers.
And what are you seeing a lot of in A&E at the moment?
I don't know anymore because I'm not there. Paul, what are we seeing in A&E?
The ward is full of RSV positive cases. It's
In
just
August.
like, yeah, midwinter. Yeah. An RSV kid getting sick. Normally, it's been the metapneumo or adeno or parainfluenza who would be sick, but we've got RSV little ones 3-4 months on vapotherm. So, yeah, if you're worried about potential respiratory deterioration, even if the little ones don't have risk factors, weren't prem, no chronic lung disease, you know, we're happy to see, because it's difficult to predict the ones who are needing to be admitted at the moment.
And I made a website about it, which is called morethanacold.co.uk. So you can direct parents to it. It's for people. It's an educational website.
Oh, that's fantastic. So we have an Accurex system where we text patients' information. So this sounds like a great Accurex template.
Yeah, there we go. Yeah, it's the company that Abbott that makes Pelivazumab, who for their sort of benevolent arm do sort of information for patients, and so they employed me to make a video and write some stuff about it. And I said, I'll only do that if you don't mention Pelivazumab, because I don't want the whole population to want that for all their babies. And so there is no mention of it in the website. It's just educational stuff.
And what did you say that was called, Sue? More Than a Cold.
It's called morethanacold.co.uk.
Okay. Brilliant. Thanks, Sue. Well, we're reaching the end of our time now, but do any last minute burning questions, please post in the chat, because we need to use this time with Sue wisely to get those learning these addressed. Oh, thanks, Andrew. Andrew's just posted some information about the Little Orange book from Newcastle in the chat. Thanks for that.
Excellent.
All right, well, unless there are any other further questions or comments, I think we can start wrapping up the meeting.
Thank you very much.
Thank you very much. Really thank you to Sue and to Paul for coming along. It's brilliant to have an interactive meeting, and really, really great. It's amazing what you can do virtually. So thank you. Really great. We've even taught on non-medics here a thing or two about rashes, so been really excellent. So thank you very much for that, and we would look forward to doing another paediatric session in sometime next year. So thank you, and hope you enjoy the rest of the summer. Our next meeting, there is a Wednesday, which is the 1st of September. The next meeting actually is the 8th of September. I've actually just clocked, Anisha, it's actually the second day of the Jewish New Year, Rosh Hashanah. So can you just actually post in the chat if you can't do it, because it's the Jewish New Year, because if there's huge numbers that can't do it, we might want to do another date.
We did actually move that, Charlotte, from the 1st. But yeah, as Charlotte says, please, because of another clash, but please post in the chat, if that's going to cause a problem, and then we can try and change it.
And we'll try to go with where most people can do. So, as we said, really hope that you get to enjoy the summer. Even if you're working, at least the roads are a little bit quieter. Hope you get to go out in the evenings when it's and appreciate being a little bit quieter. But hope that those of you who do go away, whether it's in UK or abroad, do get to have a fantastic time, because you've worked so hard over this last year. from August to August, and we're hugely appreciative. Thank you very much to Anisha for arranging these meetings so fantastically, and for the rest of the training hub, and for all of the support, and to our colleagues in the CCG. And you've met Kat today, who's the new head of primary care, and thank you to the Federation. And it's just fantastic that we're all doing this collaboratively, and we got up to, I think, 108 people at one point, so despite it being August, that's huge numbers. So I'm glad that you continue to enjoy it, and we'll be into, I think a lot of people say they can't do that 8th of September, so we'll probably have to think of another date. So thanks very much to everyone, and let us know if you have any other topics you want to cover. Many thanks, and take care. Bye.